Epilepsy, when we define that the patient is having epilepsy, 2 seizures or more, but 2 seizures or more unprovoked. And if the patient will come and saying that I have a seizure after I had hypoglycemia, let's say hyponatremia, hypocalcemia, these are provoked. So he has seizure, but he doesn't have epilepsy. So she started having seizure, right? This was described by herself, that I lose consciousness and I shake. Why I am showing this video? That you see the description, which is having pelvic thrusting, shaking the shoulder. This is not a true seizure, this is psychogenic. She elevated her arm, she didn't drop it over her face, she gave away. That's why we don't say that this is a seizure. This is a spell. But this is a psychogenic, this is not a true seizure. It will asymmetric. We have turning, eyes are closed during the spell. Another type of spell of loss of consciousness. You see here, this is a syncope.
Only 10% of the subjects lay motionless during syncope.
The blood pressure dropped down, but you see here, it didn't have any jerks. But this is syncope.
Occasionally, myoclonus was generalized and symmetrical.
The parents will come to me and tell me that he had jerks. So it will confuse me, oh, this is myoclonus, this is a true jerks or not. In real syncope, when the patient develop severe hypotension, can have myoclonic jerks. It's type of hypoxia to the brain, let's say, small drop in the blood pressure or in the heart rate can develop some myoclonus. But here, it's difficult to tell if I will not see the spell. That's why we tell them to take videos. We admit them for a long-term video EEG. Try to tell them stand up to induce the blood pressure, the hypotension, maybe by hyperventilation, and so on. Another kind of syncopal attack also.
Could manifest itself
You
with
see, the myoclonus is severe, vigorous myoclonus. The parents or the father or the witnesses will tell you when he lost consciousness, he developed jerks. These are not epileptic jerks. These are myoclonic. But these are myoclonus, but not epileptic myoclonus. These myoclonic jerks secondary to vasovagal syncope, drop in the blood pressure, in the heart rate, and so on. Let's say this is a true seizure. So you can know a little bit the difference. Now he will develop focal seizure. Start having some mouth deviation to the left, you see? Now he will develop twitches over the left face. You see? This is focal seizure. But you see, the nurse is talking to him, he can't answer her. That's why we tell you, we ask you to talk to the patient. Why? To see if he's having simple partial seizure, we'll talk about it, or complex partial seizure. And based on the new definition, I will tell you the new definition of complex partial seizure and simple partial. Partial, but no loss of awareness. Sometimes he can have partial with loss of awareness. Maybe reddish, staring, no response, and so on. During photic stimulation, the patient, what? You noticed what she developed? هذه المايوكلونيك jerk. شفتيها؟ It's very similar to the jerks that the patient developed after syncope, but here it was provoked or induced by photic stimulation. This is a myoclonic jerk. This is epileptic myoclonus, you see, induced by photic stimulation. And on the EEG, the patient, you see, on the EMG, he developed myoclonus, and on the surface EEG, it showed generalized spike wave discharge. He was not responding also. There was a delay in answering the question. This is what we call absence seizure. It's acute, sudden onset of the loss of awareness, unresponsiveness, eye blinking, staring for a few seconds. Then here, back to normal, and she starts responding and answering back to normal. On the EEG, we can see generalized spike wave discharges, but lasting for a long period of time. You see here. You see when here the nurse was asking her to raise her hand. When he saw the discharges, he started asking her, raise your hand, raise your hand. Here she started raising. Okay? Delay. So this is generalized spike wave discharges with clear loss of awareness, unresponsiveness. So we call that this patient is having absence seizure. Another video you see here, during hyperventilation. Okay? Hala, pay attention to her eyes, her hands. You see? Myoclonus and eye blinking. Okay, with myoclonus. This is myoclonus with absence. Okay. Also, this is a generalized epilepsy. So let's go back to our talk today. Diagnosis of epilepsy relies on several aspects. You see, 1, 2, 3, history. It's not EEG, it's not MRI. But here, the EEG supports my diagnosis. This EEG will help me and will tell me that this patient is having idiopathic generalized epilepsy. So I will start him on medication. I cannot discharge him without medication because based on this EEG, at home he can have a seizure anytime or early morning. So seizures consists of spells, loss of consciousness, awareness and shaking. In general, the seizures are very brief. The seizure does not last more than 1.5 minutes. After that, after 3 minutes, you will have a status, a continuous seizure. But usually the real seizure, the GTC, the generalized tonic-clonic seizure, will last up to 90 seconds. They are stereotypic. They look like each other, okay? Unless the patient is having several types of seizure. But usually the seizure, it looks the same. They are stereotypic, okay? Clear beginning and evolution, it should start clearly with, for instance, myoclonus, loss of awareness, eye blinking, then he will develop a generalized seizure. Before we called it grand mal seizure. Okay, now it's a secondary generalized tonic-clonic seizure. And of course, I have to have EEG findings with EEG. That's why we admit the patient. We see the clear evolution. This is absence seizure. Here it's a clear onset and a clear offset. Clear onset and a clear offset. So the seizure consists of spells. They are brief, stereotypic, okay? Clear beginning and evolution, and they usually associated with EEG findings. So we'll go back to our case. In the ER, he was noted to be drowsy and confused. So his friend brought him to the emergency after he had a seizure. Half an hour later, he is back to normal, but he was amnestic to the event. He didn't remember what happened. That's why we tell the patient, after you woke up, do you remember anything? Sometimes he will tell me no, sometimes he can't tell me. But usually in the true seizures, he cannot tell. I don't remember what happened. I woke up in the emergency unit and I told my brother who brought me to the emergency, what happened? He's confused. Witnesses, Shuhud, reported generalized tonic-clonic movement with urinary incontinence. His friend showed and he could explain to me that he developed a generalized tonic-clonic seizure and he developed a urinary incontinence. But pay attention, sometimes the description of the witness is not clear. All type of loss of consciousness and shaking can describe by the witnesses as a generalized tonic-clonic. عمل تشنج وشد وصار ينفض. You see, you remember the psychogenic and the syncope? The witness, if he is not medical expert, he can tell me that he has shaking, he lost, he uprolled his eyes, he was staring, he closed his eye, and so on. So now the patient had a spell, and according to the description by his friend, he had seizure, true seizure, GTC, postictal amnesia, urinary incontinence. Okay, but here the next question will come to me: is this seizure was provoked or unprovoked? So till here, I could know by the history that this is a seizure, right? Okay, but now I should ask myself: is this seizure was provoked or unprovoked? Provoked, was he sleep deprived? That's why we do for him several labs in the emergency. We do in sodium, potassium, ECG, urine, temperature, blood pressure, heart rate, and so on. Okay, to exclude these factors that can provoke seizure, like hyponatremia, hypocalcemia, alcohol withdrawal, okay, medication, acute insult to the brain, stroke, and so on. Sometimes the patient can have a true seizure provoked by sleep deprivation. He had a party last night, New Year evening, Christmas evening. The young lady didn't sleep all the night. She can have a seizure, and sometimes the seizure is true. Okay, and why? Because sometimes in idiopathic generalized epilepsy like GME can have seizures only provoked by sleep deprivation. If they are not sleep deprivation, no need for medication even. Although they have on the EEG generalized spike wave discharges and true seizure. Because their seizures are only provoked by something. If they can exclude it or avoid it, they don't need medication. You see? But this is rare. So here, so now we excluded that he didn't have a provoked seizure. So we did all the lab study, investigation in ER or in hospital, or are normal. So his seizures are what? Unprovoked. We exclude everything. So his seizure is unprovoked, but he had only one seizure, single. If he will tell me that, oh, okay, doctor, but 1 year ago I had a seizure, or 6 months ago I had seizure, so this is not single. So this is 2 seizures, so we have to start medication. So here, if it is single, like in our nurse, okay, we will wait. So I waited. I told him, you have to wait. You see, single, I wait. If he told me that I had a seizure 3 months ago, or, oh, okay, I remember, doctor, my mother told me that one time I had a seizure, but I forget to tell you. So he has 2 unprovoked seizures, or more. So now I have to ask myself again whether this seizure is generalized insomnia or focal seizure, مثل هذا الصبي اللي فرجيتك عنده facial twitches and mouth deviation. Why this is important, Rani? Because here the treatment different from this treatment. The prognosis is different from this prognosis. So this is very important. Okay? This will lead us to another lecture in the future about the treatment. You see, or you notice, we give Dipakine, Tegretol, Trileptal. So what is the difference? This is a special topic. Okay, sodium channel blocker, calcium channel blocker, NMDA, AMPA, okay, Keppra on the SV2 protein. Why Dr. Fawaz chose Keppra for this patient? Why I didn't start him on Tegretol, I started him on Dipakine. In general, for generalized, usually the most effective treatment is Keppra, levetiracetam, Dipakine, clobazam, dibenzodiazepine, etosuxamide, Zarontin, and so on. In partial, you can use most of the medication. Even Dipakine works for partial, but it's not as good as carbamazepine, the sodium channel blocker. Keppra can use for both, for generalized and for Keppra. For instance, if you give Zarontin, etosuxamide, for absence, it's very good. The most effective treatment for absence is Zarontin. If you give Zarontin for this child with focal, it will not work. Why? Because Zarontin mechanism of action works on the calcium channels or the T-type calcium channels in the hypothalamus. This does not work for partial seizure. Based on these trials and research and the Tegretol, if you give it to absence patient, if I give Tegretol or Triliptal, the absence will worsen. It will get worse. Lamictal, if I give it to the patient who I showed you with myoclonus, Lamictal can worsen the myoclonus sometimes. You see? Keppra works for both. This is one of the advantage of Keppra, that works for both. But it doesn't work for absence. It helps a lot with myoclonus, but sometimes the patient will keep having myoclonus, but the frequency of myoclonus will decrease significantly. That's why I add sometimes benzodiazepine like clobazam and clonazepam. You see? Why this is very important? Why we ask the patient a lot? Why we review the EEG to decide what type of treatment I should start the patient. So, seizures classification, we have partial seizure and generalized. Partial, it's coming from one area of the brain. That's why it's partial. If the partial does not spread to involve the other hemisphere, he will have simple partial seizure. Focal, like in this boy, focal seizure, but no loss of awareness. Okay? If the partial seizure spread to involve the other hemisphere, he will develop complex partial seizure, which is a focal seizure with loss of awareness. This one, focal seizure with no loss of awareness. Okay? If the seizure spread to involve all the areas of the brain, the patient will develop a generalized tonic-clonic seizure. Okay? So here, we see partial seizure divide to simple partial. Awareness is normal. But what type of simple partial seizures the patient can have? They can have motor, like in this guy, sensory, I have numbness, abnormal sensation, autonomic, nausea, vomiting, and so on, psychic, behavioral changes, okay? So complex partial seizure, awareness affected. But the same, it also can have motor, sensory, psychic, autonomic. Secondary generalized, if it's secondary, he will have loss of consciousness and generalized tonic-clonic seizure. You see, the patient can have only simple partial. The simple partial can spread to have complex partial seizure and stop here. Sometimes no, he will develop GTC. Sometimes simple partial seizure immediately to GTC. Sometimes complex partial to immediately to GTC. Sometimes GTC by itself, with no aura and no any other preceding symptoms. There are several types of idiopathic generalized epilepsy. In this case, absence. You see absence. Absence, idiopathic generalized epilepsy. Generalized tonic-clonic seizure can be symptoms of idiopathic generalized epilepsy. And GTC can be a symptom of also partial seizure. Okay? Myoclonus, tonic, and atonic. Okay? Tonic, يعني بشد.
Stiffness.
Increase in the tone up to 10 seconds. Atonic, loss of the tone. Okay? Myoclonus, sudden jerk, lasting less than how much?
Less than milliseconds. 2 to 20 milliseconds. 20 milliseconds. 20 milliseconds.
Less than 200 milliseconds.
200 milliseconds.
So, in the next lecture, we will talk about the EEG findings. This is an introduction to epilepsy and seizures in general. Because if I will start immediately with EEG, وصونا مش عارفة what is partial, what is generalized, how we يعني in general. This information, by the way, some neurologists, they don't know it. Okay? So don't think that this information are easy to take or easy to understand, because practically we have to decide. Many neurologists, you don't know them. How many psychogenic non-epileptic spells you saw by yourself on medication?
Yes. Yeah.
Tens of or hundreds, right?
Yeah.
Sometimes on 3 medication,
Yes.
right?
Yeah.
Syncope. Okay? Now I will show you from my phone one child having recurrent spells of loss of consciousness. Whenever he plays, he loses consciousness, become pale, and he faints. We did for him several EEG and all are normal. I didn't start him on medication. He came, I think, on medication because I was, from the history, I was thinking, not because I'm a genius, but I was thinking that he doesn't have seizure. He's having syncope. But what is the cause of his syncope? I couldn't find immediately. I did for him ECG, if you remember, was normal, echo normal. Holter monitor for 24 hours was normal. But I was insisting that I will not start him on medication. I sent him to cardiologist. Okay, he couldn't find anything. Okay, he went to Lebanon to a major center for cardiology. They agreed with me that he may have syncope, but they couldn't find and they couldn't capture the spell. So they waited, and I waited, but no medication. Next, we decided to put for him pacemaker to capture, like Holter monitor, but it's implanted. Okay. 1 week ago, he developed this. His heart stopped for 5 seconds. Last week, he lost consciousness while he was playing. Okay. So the mother and the father brought him back to the doctor. He put the device on the computer, attached it to the computer, and at this specific time, he was searching what happened during this time. This is the EEG, you see, the ECG, not EEG, ECG. Normal heart rate, tachycardia sometimes, and here bradycardia. Now you see, bradycardia, here pause.
رجعت اتضربت تاني وبعد كده حصل توقف تاني لمدة ثانية 2 3 وبعدين رجع ضربتين وبعدين حصل 1 2 3 4.
Here 1 2 3 4 5 6 7 seconds. You see, this is the normal heart rate. Can you see? This is the heart rate. But here was flat. But then the heart rate returned back to its normal, bradycardia then back to normal. So this was cardiac arrest or pause. Okay, it's not. We don't name it cardiac arrest because the heart doesn't stop. It's only a pause. It was very long pause. Less than if the pause more than 3 seconds, we have to have put permanent pacemaker because now it occurred for 5 seconds. If it will occur for more than 10 or 15, he may have cardiac arrest. So this is a true case of syncope. If I started him, or if anybody started him on Dipakine, on Keppra, for how long? First, they will label him that he's having epilepsy for all of his life. Epilepsy classification, history, EEG, MRI, can tell me whether this seizure is focal or generalized. About the new classification, so this is 2017 classification. You remember? We were saying simple partial, complex partial, generalized. Now, this terminology, we should not use it anymore. لأنه تعمل confusion. It will lead sometimes to other doctors. Oh, simple partial. There is loss of consciousness or not. Complex partial. What does it mean? Awareness lost or not lost. So now that's why they are saying we have to name it only focal onset seizure. So if I will ask you again what the patient is having, you can tell me, doctor, he was having focal onset seizure, aware.
So simple
Or
partial.
focal seizure, doctor, with impaired of awareness.
Complex partial.
We are not using complex partial or simple partial anymore. Even in the journals, in the conference, you will not hear it anymore. But sometimes I say it, other doctors say it to make simpler. Okay? And you should also tell, you should continue. Focal onset seizure, aware or not aware, with motor onset or non-motor onset. This boy had motor onset, twitching. Sometimes it will not be motor onset, sensory onset. You will say motor onset or non-motor onset. Okay? Any other detail, it will be written in the history. Focal to bilateral tonic-clonic seizure. We are not using any more Dahlia with secondary generalized tonic or secondary generalized tonic-clonic seizure. If it's having focal seizure, to bilateral tonic-clonic seizure. It's simpler. Okay, so now the definition of focal onset seizure: focal onset aware or
unaware.
impaired awareness, motor onset or non-motor onset focal seizure. If there is no GTC, you stop here.
Stop.
Focal, for instance, this guy, this boy that with facial twitches, he had Dr. focal onset seizure, aware. If you will have GTC, yesterday he developed focal onset seizure, aware, to tonic-clonic seizure. Don't use secondary bilateral generalized tonic-clonic seizure and so on. Generalized onset, you say it is generalized, whether it is motor, tonic, or clonic. Sometimes he will have only tonic without the clonic. So he was having generalized tonic seizure, generalized clonic seizure, generalized tonic and the clonic seizure. Okay? Generalized absence. So generalized non-motor, only absence, because non-motor is only absence. Generalized motor seizure, you will tell me. I will ask you myoclonus, or you will tell me generalized tonic, or generalized tonic-clonic, or generalized motor with myoclonus. I know that if this patient developed myoclonus, left facial twitches, and head turned to the left side. Focal, aware, motor, easy. Okay? Sometimes in our paper on history, you notice unclassified seizure, unclassified spell, unknown. I cannot know from the history. Sometimes it's very poor historian. I cannot identify whether he's having a focal or generalized. Okay, so I say unknown onset. The patient sometimes come to you and say, I have only generalized tonic-clonic seizure. No aura, no focality. The EEG is normal, let's say. I say that he's having unknown onset of seizure, whether it is motor or non-motor, but I cannot tell by the history and the EEG if it is focal or generalized. I say it's unknown onset. And sometimes you see my notes or Dr. Maher or Ahmed Midhat in the unclassified. I cannot tell what the patient is having. I say rule out syncope. I say rule out, sometimes unclassified. I can't know what this seizure is. That's why I do further investigation, EEG, MRI, long-term video EEG monitoring. I see him another time. Several clinic visits will help me. This is all the classification. Epileptic seizure, partial, simple partial, complex partial, generalized, absence, myoclonus, clonic. Why this classification is important? Because it led to another classification. So focal onset, aware, impaired awareness, like the one I showed you. Focal to bilateral. Here, why they put this classification? Because sometimes in the focal onset seizure, the patient can have automatism, can have atonic, but it's partial atonic, can have clonic, but it's partial, not myoclonus, can have spasm also, because before in the older classification, whenever you hear spasm or atonic or myoclonic or tonic, you think immediately, so this patient is having idiopathic generalized epilepsy. Now, no. They revised the classification. In the focal seizure, I can have a focal spasm coming from one area of the brain. So, although he's having spasm, or let's say atonic, seizure or myoclonic can be partial. Sometimes you say focal aware, type of motor you say focal spasm, focal tonic. Sometimes we will have tonic over one area of the body, right?
Yes.
Focal clonic, focal atonic, and so on. And non-motor also, autonomic, sensory, emotional. So before, these type of seizure were put only with generalized epilepsy. Now, in the new classification, I can have focal with spasm, atonia. ليش عم بقول هذه يا سونا؟ Because before, in the generalized seizure, they only put absence, myoclonus, tonic, clonic, and atonic only in the generalized part of the type of seizures. In the focal, they didn't mention this. This is what it was in 1998. Then they revised the classification in 2000, I think, then in 2004. But the latest one is 2017. They changed the classification of the seizure. It helped us a lot. This is a basic approach to epilepsy. Basic definitions, just a basic definitions. How we approach any patient coming to us with a seizure. Okay? Last one, I will show you EEG of another one. True also seizure. So you see the interictal EEG. So now I showed you the EEG of generalized. You remember generalized? Okay? Sometimes focal spikes located only over F7 and T3, which is left temporal. So F7, T3, these are left temporal. So F7, T3 is mid-temporal.
Okay.
So we call it, this EEG, the interictal EEG findings, showed left anterior mid-temporal spikes between proximal hot F7, T3 spikes. So these are focal. So the nurse noticed something. She entered the room and started talking to the patient. The patient was confused. She's looking around. She was not able to read. Now she started responding, right? Before she was confused. Another example, she was holding her telephone with her left hand and something happened. The nurse entered the room. She started moving her legs. Here, maybe she is not using her phone adequately. It's just like automatism. Okay? The nurse entered the room and some dystonia over the left side. You see?
But there was no stiffness that day.
Maybe it ended. You see, she is confused. شايفة يا سونا؟ بتبص.
Confused.
ما بتردش. She's not answering adequately. Now started answering. But before that, she was confused. So, by definition, according to the new classification, focal seizure, impaired awareness. Focal seizure, impaired awareness. I cannot say this is generalized seizure, impaired awareness, right? This is focal seizure, impaired awareness. Motor also. I will show you another example. We are not observing the audio, I'm only observing the video. She is confused.
Confused.
But here, the seizure stopped, but she was still confused. But here, during the spell, we noticed some muscle artifact. But here you see some rhythmic discharges over the left side of the brain, right?
Yes.
You agree?
Yeah.
This is the evolution. It starts like, let's say delta, then 1, 2, 3, 4 delta, okay, over the left part of the brain. Here it's spread to involve the central and the right hemisphere. But here it was only over the left, rhythmic delta activity. So the seizure was coming from the left temporal or left frontotemporal area.
So I saw one patient while doing HV, is like a 13-year-old.
Yes.
And rhythmic slow waves was there, with the patient having mild automatism and unawareness. But it's less than 10 seconds. It can be taken as a seizure.
Yes, sure. And here also, here she developed some oral automatism before. Focal, impaired awareness, motor, some motor مثل ما قالت lesion. And on the EEG, Here the EEG is not very clear because there is a lot of artifact. But I can here appreciate some rhythmic movement over the left temporal area. More than the right, you see? It's not very clear like the one I showed it before. Okay, this one is more clearer, like here, you see? If you put it on the average, it's only coming from the left, the F7, T3, and FP1. So it's left frontotemporal. So I showed you example of clinical focal seizure, simple partial seizure, clinical focal impaired awareness with some first focal no impairment of awareness, focal impaired awareness with some motor findings, generalized like absence, and the other one was myoclonic jerks, and on the EEG generalized spike-wave discharges. Syncope, two examples of syncope and the myoclonic jerks after syncope. Okay, because of the hypoxia of the brain, that drop in the blood pressure can develop some myoclonus. And the psychogenic non-epileptic seizure, like in the example here, okay, and absence with myoclonus. So this is a basic information about the approach of epilepsy. Classification is very important, the history is very important, and diagnosis is very important because it will help us to treat the patient appropriately and adequately. I cannot give Tegretol for absence, I cannot give Tegretol for myoclonus or Lamictal, and so on. Next meeting or next lecture, we'll start about some EEG. So when you are reviewing the EEG, seeing EEG on daily basis, now you can identify what's normal, what's abnormal.